Week 7, this is the third and final lecture for this week on spine and pelvis, part 1 of our 2-week lecture series on this topic. Now, in the preceding lecture episode, we spoke of sacroiliac or core stabilization. This refers to the ability to maintain and control proper sacroiliac positioning to provide trunk stability with correct movement over the pelvis and lower extremities. This ability to maintain and control proper positioning allows for optimal function and performance of the extremities. The foundation for any successful movement is stability. The body is designed to provide stability during functional movement through its core muscles. As examples, the shoulder joint is stabilized by the scapular muscles. The hip is stabilized by the gluteal muscles. Because the core is so important to spinal stability, we will go ahead in this lecture episode to discuss the mechanics, rehabilitation, and pathology. So here we have the various components of the core. And essentially, the core muscles form a box or cylinder at the innermost level of the trunk. This is highlighted in figure 17.2 from your textbook and shown on the right of your screen. The spine itself, I've been speaking to this idea that it is weight-bearing. However, it cannot really support any significant load on its own. In fact, the textbook mentions that the spine itself will collapse when there is about 5 pounds applied to it. So it's not inherently able to withstand significant loads without the support and stability from the surrounding muscles. When we speak about stability of this region, we often think about the core. As I've mentioned, the trunk is thought of as a box or cylinder of muscles that help to support the spine or vertebral column. At the top of this box, you have the diaphragm. At the bottom, or most inferiorly, you have the pelvic floor. The front of the box, or more anteriorly, you have the abdominal muscles, as you do on the sides as well. On the back is the paraspinals and the gluteals. In essence, when we are talking about core stability, we are really referring to the stability provided by the muscles in the pelvis and trunk, and that is going to facilitate functional movement. Now, this next slide goes into a little bit more detail of the muscles of the pelvis and trunk as highlighted on the right of your screen, both the outer and the inner core muscles. Stabilization relies on your outer core muscles, including the external obliques, rectus abdominis, erector spinae, and the gluteal muscles, as shown once again in this figure on the right of your screen, which is 17.3 from your textbook. Notably, there is a significant relationship between posture and back pain. So we've spoke about posture in some of the preceding lecture weeks. And so posture is vital when it comes to both injury prevention, but also when we think about rehabilitation as well. When we spoke about posture in preceding lectures, the idea is that we can prepare a rehabilitation program, we can implement it, but at the end of the day, if the patient who is injured has poor posture and nothing is done to remedy that poor posture, then the affected area will still continue to suffer, and recovery or rehabilitation efforts will still be compromised. We need to correct posture. This relies on our trunk stabilizers. This relies on having a pelvic neutral type position. Notably, when we look at these muscles of the pelvis and trunk and creating a very solid cylinder to withstand compression and loads that are placed on it, it relies on something known as intra-abdominal pressure. So when we create intra-abdominal pressure, that is going to facilitate a very strong core. In this case, both the diaphragm and the pelvic floor muscles will increase the intra-abdominal pressure when they are engaged. In addition, the pelvic floor and the multifidus muscles are also activated alongside the transverse abdominis. Therefore, you can think of the diaphragm as having two responsibilities. Most often, we think about its contribution to respiration, but it also is integral to postural stability. So when we think about maintaining a strong core, we're really thinking about intra-abdominal pressure that is brought about by the engagement or the contraction of those muscles. As a result, we need a coordinated synchronous effort of these muscles. So once again, it's the abdominal muscles, the pelvic floor, and the diaphragm that are going to contribute. Next, I should distinguish between the trunk movers versus the trunk stabilizers. Just to be clear, the trunk stabilizers are the local muscles. The trunk movers are the global muscles. The local muscles are those that are close to the center of the body that provide stability because their moment arm lengths are too short to provide significant movement. This is in contrast to the global muscles that provide the larger or gross trunk motions because they are at a distance from the center of motion and have longer moment arms that cover multiple spinal segments. Examples of our global muscles, once again, that are imperative for stabilization include the rectus abdominis, the external obliques, and the quadratus lumborum, and the erector spinae. The erector spinae, I should note, is actually composed of large paraspinal muscles that span the various vertebral levels. Examples of your local or core muscles, sometimes known as your stabilizers, include the transverse abdominis, the pelvic floor, the diaphragm, the internal obliques, and the multifidus. So these tend to be that inner core of muscles, and both of these groups contribute to stability during movement. A deficiency in these muscles, both the inner and outer core, are going to place other body segments at risk of injury. So one such example, if we think clinically, core instability has been linked to knee injuries as an example, including an ACL type injury. And another example, patients with low back pain often have deficiencies when it comes to their hip abductors and rotators. Lastly, I'll touch on the concept of pelvic neutral, and to do so, I'll actually advance to the next slide. There is also a video in chapter 17, which shows in real time how to work with a patient to obtain a pelvic neutral type position. Nonetheless, we have a figure, a three-part figure that we're going to go through. So in this particular scenario, we're trying to find pelvic neutral, and that essentially is a postural position where you have the least amount of stress being placed on the lumbopelvic hip complex. In pelvic neutral, the trunk, the arms, the head are balanced on the pelvis. As a result, there is minimal stress on the joint and minimal muscle activity is needed to hold that pelvic neutral position. Pelvic neutral can be difficult, particularly for patients with low back pain. Yet patients can often obtain a pelvic neutral position by being seated. What you can see in the figure on the top left is that the patient is seated with the hips and knees at 90 degrees. They place their index and middle fingers on the left and right ASIS, or anterior superior iliac spine. The patient rocks their pelvis as far as possible posteriorly and notes the end position. They do the opposite action by rocking the pelvis as far as possible anteriorly, noting the end position once again. Now, rocking back and forth between these two extremes, one can move through a progressively small range of motion until they arrive at a mid position of this range. This is the patient's pelvic neutral. This is the center of the pelvic motion where the spine should be balanced over the pelvis, as you can see once again in the diagram at the top of your screen. Everyone is different. Everyone's pelvic neutral is different or unique. It depends on an individual's range of motion and their ability to move the pelvis. Once patients are able to achieve a pelvic neutral type position, they should be maintaining this position during various activities. It is difficult at first when individuals might be accustomed to poor posture or muscles that may be lacking in strength and endurance. However, with proper rehabilitation, patients should be able to improve their muscular strength and endurance, and therefore be able to hold this position more comfortably and for longer durations. And so maintaining pelvic neutral relies on several different concepts. Diaphragm recruitment is the first key, and for this to occur, the diaphragm should be recruited for inhalation, and the rib cage must move into an exhaled position first. Abdominal hollowing and bracing activities. There are 2 exercises that help to facilitate the transverse abdominis, internal obliques, and pelvic floor muscles, and those are abdominal hollowing and abdominal bracing. The first term, abdominal hollowing, is when the abdomen is drawn in to facilitate the action of the transverse abdominis, and abdominal bracing occurs when more of the abdominal and back muscles are activated to co-contract. As I've mentioned before, both local and global muscles are needed for optimal core stabilization, and therefore exercises for both of these groups should be included in any rehabilitation program. Once again, the global core muscles are those in the trunk that are furthest from the trunk center and considered to be the movers of the trunk and spine. Once again, these include the rectus abdominis, the external obliques, the erector spinae, and the quadratus lumborum. They are the outer muscles. Unfortunately, these same muscles often lack strength after an injury and should be part of a rehabilitation program. Taking a step back, I skipped over the multifidus recruitment, and that should be activated alongside the transverse abdominis. However, it's usually not recruited in patients with low back pain, as they may have atrophy of this muscle group. And just to be clear, it is in close proximity to the erector spinae muscles. It is a small muscle located next to the spinal column. And now we'll move on to the body mechanics. Which refers to the way the body is positioned, the way the body is essentially used during activity. When there are incorrect body mechanics, this places undue stress on the body segments. And so an awareness of good body mechanics, once again, is integral. From a personal perspective, body mechanics can improve efficiency during the application of movement and exercise, and it also leads to energy conservation as well. A neutral spine is part of good body mechanics, and a neutral spine essentially will permit forces to be transmitted through the body. So for example, forces from the lower extremities can be transmitted to the trunk and upper extremities. Good body mechanics also can be modified by increasing one's body stability through lowering the body's center of mass. This can help us to resist outside forces. An example, if an individual is standing upright and they are pushed, it is easier to move, or easier for the person to move if they've been pushed, depending on their center of gravity. So this is one reason why in football and rugby, players will be often in somewhat of a squatted position. Also, broadening the base of support is another way in which we can increase that core stability. If, for example, that same individual stands with their feet together and they are pushed, it will be much easier to push them over or off balance if their feet are together than if they are apart. So broadening the base of support helps with stability. Another principle of good body mechanics is to stand in the direction of the force application. This helps you to transfer force from the legs. So based on all of these principles surrounding body mechanics and how we can increase stability, individuals and rehabilitation clinicians can start to think about concepts around proper positioning to be able to execute activities. For example, if we take a gymnast must be able to engage their core as they complete any sort of activity on the bars. A weightlifter's back must be extended as they lift a weight overhead. These are simply a couple of examples of how, once again, good body mechanics are necessary for activity. Three further examples in the rehabilitation realm. If we think about everyday activities, we have lifting, pushing, pulling, and sit to stand. Seemingly very basic movements, but are also very important to do correctly. Firstly, proper lifting technique. Shown in figure 1713, you can see the individual lifting what looks like a heavy box. What you can see is that the back should remain unchanged during the activity. The legs are being used by flexing the hips, knees, and ankles to move or lift the object. Next, proper pushing technique, as shown by the individual in the top left of the screen. The spine remains flat and extended with the core engaged to provide force transfer from the legs through the extremities to the upper extremities. Lastly, a proper sit to stand position in the bottom right. The spine remains properly aligned while the hips and the knees are flexed to move the center of mass from sitting to standing. Notably, one center of mass should remain over the feet during the sit to stand activity. Lastly, there are several issues that must be addressed during a rehabilitation program, and common deficiencies that present include the following. So these are highlighted in your textbook, but it's very common for patients to have reduced proprioception, reduced muscle endurance, a lack of muscle coactivation, delays in core muscle recruitment, incorrect diaphragm use, which we talked about the diaphragm playing an integral role in increasing intra-abdominal pressure to create stability and support. There can be imbalances when it comes to the muscles in and around the hip, and overall reduced stability owing to all of these factors. Instability not only increases a person's injury risk, but also prevents optimal performance by limiting the force transfer through the trunk and reducing efficiency and costing additional energy. So the various rehabilitation intervention techniques are shown here. An example of soft tissue mobilization would be trigger point release. There's also joint mobilization, there's flexibility activities. These can include manual techniques and exercises, and these flexibility type exercises can be incorporated early on during rehabilitation and continue until goals are achieved in terms of range of motion. As with injuries to other body segments, rehabilitation processes, when we think about the different phases, really focus initially on reducing pain, muscle spasm, and swelling before moving on to activities like flexibility and then on to muscle strength and endurance. As a result, when we think about strengthening exercises, the spine, the core, the trunk, the pelvis, all of the muscles surrounding those structures should be focused on as part of an exercise to improve stabilization. Examples of strengthening exercises. So core muscle strengthening exercises, there are two groups of exercises called the dead bug and the bird dog exercises. These are rather basic. They are described in the textbook. You can also refer to the internet to have a look at how they are demonstrated. But the dead bug exercises typically involve moving the arms or legs from a supine position, while the bird dog exercises are performed while one is on their hands and knees and involve similar extremity movements while recruiting the core muscles to provide stability. There are also progressions for these types of exercise that are further described in your textbook. Once an individual has achieved increasing muscle strength, neuromotor control, then they are able to perform more trunk rotation type activities or potentially plyometric exercises that start to get at the functional and performance specific types of exercises, which typically involve higher forces, quicker movements, and multiplanar motions. Nonetheless, pelvic stability should always be maintained while executing these higher level functional and performance specific exercises. And that concludes this lecture episode.